Hi, my name is Yervant Ichkhanian. I'm one of the internal medicine residents at Henry Ford Hospital. I'll be giving a brief overview about our recently published study in GIE, which investigated the role of GPOM among patients with gastric neurostimulator. In this video, I'm going to be giving a brief overview about our results. This is going to be followed by a discussion by Dr. Piraka and Dr. McFarlin. Gastric neurostimulator and more recently GPOM are interventions that are offered for patients with refractory gastroparesis with the aim of providing symptomatic control. Unfortunately, both of these interventions are associated with suboptimal and unpredictable clinical outcomes, likely secondary to the complex pathophysiology of the gastroparesis itself. Therefore, in this study, we investigated whether patients who have failed to improve to gastric neurostimulator would benefit from GPOM. This study was a multi-center retrospective case control study that involved 7 US and 1 international center. The study was conducted during the time period of October 2018 and August 2021. The inclusion criteria was consecutive patients with gastric neurostimulator who underwent GPOM as a salvage treatment for the management of clinical failure were included. These were labeled as the cases, and patients who underwent GPOM without gastric neurostimulator for the management of refractory gastroparesis were labeled as controls and were included in the study as well. The primary outcome of the study was clinical success among the case group, which are the patients who underwent GPOM after gastric neurostimulator. The clinical success was defined as per the GCSI, or Gastroparesis Cardinal Symptom Index scoring system. In our study, we included a total of 123 patients who underwent GPOM, of which 41 were cases and 82 were controls. Among the case group, the patients were diagnosed with clinical failure at a median time of 14.6 months after the placement of the gastric neurostimulator. Also, among the case group, these patients underwent GPOM at a median time of 36.8 months after the gastric neurostimulator implantation. Technical success was achieved in all patients in the case group, and clinical success was achieved in 66%. This was during a median clinical follow-up time of 9.6 months after the GPOM. Among the case group, the mean GCSI score decreased significantly from a mean value of 2.8 to 1.5. There was also a significant decrease in all 3 subscales of the GCSI score, which included the nausea, vomiting, postprandial fullness, and the bloating. A total of 10 patients among the case group underwent pre and post GPOM gastric emptying scintigraphy test. Among these 10 patients, the mean improvement of gastric retention at 4 hours not significantly decreased from 45% to 16.6%. Among these patients as well, the gastric emptying scintigraphy improvement and normalization was reported in 50% and 30%. When we compared the cases to the controls group, there was a non-significant difference in terms of the baseline GCSI score pre-GPOM as well as the post-GPOM GCSI score. In terms of the clinical response, there was a non-significant difference in terms of the clinical success rate, which was 66% in the case group and 65% in the control group. However, the mean delta improvement in the nausea, vomiting, and the bloating subscales in the case group were significantly higher as compared to the control. Lastly, a total of 2 adverse events were reported during the duration of the study. One was a post-GPOM gastroparesis flare that required hospitalization, during which the patient was managed with intravenous fluids and symptomatic management. There was a complete resolution of the symptoms within 2 days of hospitalization. The second patient had a persistent abdominal pain after the GPOM, with cross-sectional imaging showing capillary peritoneum. This patient was managed again conservatively with a complete resolution of the symptoms.
Hi, my name is Cyrus Piraka. I'm the Chief of Therapeutic Endoscopy here at Henry Ford Hospital and the Director of the Submucosal Endoscopy Program. I want to start by talking about how we select patients for the GPOM procedure at our institution. We have a multidisciplinary team that includes Dr. McFarlin, who is our surgeon and does gastric neurostimulator placement, Dr. El-Sheikh and Dr. Ginaba, who are our motility experts, and Dr. Tarosian, who's our clinical psychologist. all working together in addition to excellent dietitians in trying to provide the best quality care for gastroparesis to our patients. That being said, there are a subset of patients who have severe and refractory symptoms of gastroparesis despite maximal medical and dietary management, and those are the ones that typically get referred for consideration of the GPOM procedure. When patients are referred from outside of our institution, we try to have a review with all the experts involved as well to make sure that they are appropriate for GPOM and that they are severe and refractory to conventional management. This is done largely not just because we want to provide the best care for our patients involving all different experts, but also to be sure that we do it responsibly, particularly given the fact that there is still fundamentally somewhat limited data to help us determine who a priori is best to select for a GPOM procedure for their gastroparesis symptoms. So, and as part of our discussion, that does include also a frank and honest discussion about the limitations about our understanding of how to determine if someone will respond, which symptoms will respond, how much they will respond, uncertainty as to how long symptoms will last, as well as uncertainty about long-term outcomes given the fact that this procedure has only been around for about a decade and we don't have super long-term data and follow-up. Sometimes these patients come to us after having a gastric neurostimulator with maximal settings in need of further treatment for severe symptoms, and occasionally it goes in the other direction as well. Fundamentally, we work very well together, and I think we feel this serves our patients best. Of course, gastroparesis is complex, and part of the discussion we have with the patients is an acknowledgement that pylorus-directed therapy is not necessarily a cure for gastroparesis, but may help symptoms if people have a pylorostenotic component to their gastroparesis, acknowledging that people may have symptoms related to lack of normal accommodation, mixing, motility, peristalsis, and so on. When people have failed a gastric neurostimulator and we're considering pylorus-directed therapy, occasionally we'll use pyloric Botox ahead of time prior to a GPOM, although this has been occurring with decreasing frequency based on revised guidelines discouraging Botox use. However, if someone has responded to pyloric Botox beyond a period of time that we would expect for a placebo effect, it's very encouraging that they may have a potential higher level response to a GPOM procedure, even though that's not yet evidence-based. A lack of response to pyloric Botox may also be helpful, although it's less clear whether that is predictive of lack of response to GPOM, particularly given the fact that people may not respond to pyloric Botox in part related to whether the botulinum toxin has been adequately delivered into the muscle itself rather than into the submucosa or into antral muscle or into the duodenal bulb. And so I think it's less likely to be predictive. But again, that's all acknowledged with our patients that have time as well. The key is really managing expectations in all scenarios. And usually patients are well versed in this and understanding that there's no simple or single cure, as they usually dealt with severe life-limiting symptoms for a long period of time. We don't routinely repeat gastric emptying scans prior to a GPOM if they've had an abnormal one in the past, independent of whether they have a gastric neurostimulator, because fundamentally someone still has a diagnosis of gastroparesis. The question as to whether that will direct us to be more likely or less likely to do a GPOM in that setting is a difficult one to answer. And part of the decision-making is an acknowledgement that at this point, when someone is seeing us for consideration of GPOM, they've already exhausted all of the other options for a severe and debilitating disease. And so we err on the side of giving them at least a chance of having symptom improvement while acknowledging the risk of no change in symptoms up to 20 to 50% based on a review of literature. At the end of the day, though, it's very encouraging that this study supports the rationale behind GPOM in patients with a gastric neurostimulator, that they're treating two different mechanisms of action for gastroparesis, and therefore the hypothesis that they may be synergistic appears to be supported by this evidence and supports our current approach to therapy. I'm sure that in the future, as more evidence arises, we'll have more clarity as to who will benefit from GPOM and gastric neurostimulators up front. But for now, given what we have, this is our approach, and again, I think this is very reassuring.
Hello, I'm Kellie McFarlin. I'm a general surgeon at Henry Ford Health in Detroit, Michigan. I'm one of the authors in the study. We were really interested in looking at the gastroparesis patient population. As we all know, it's a very challenging population to treat with varied symptoms and not a lot of standard treatment options once medical therapy fails. So our center uses a multidisciplinary approach where myself as a surgeon, GI motility specialist, GI psychology, nutrition, and advanced GI work together to collaborate to come up with a treatment plan that's individualized for that patient. I use the gastric neurostimulator for patients who are refractory to medical therapy and predominantly have nausea and vomiting symptoms. And we collaborate with our team to find out if this would be a good therapy for them and to manage them through that therapy process. I think going forward, we definitely need to look into more of the differencing in symptoms of the gastroparesis patients as far as their response to treatment effects, and looking at more causes of the idiopathic gastroparesis patients. I think that the study that shows combined therapies of GPOM and gastric neurostimulator therapy might lead us to future randomized control studies to really show whether this process should eventually be done together or if there's a certain sequence that may benefit a certain patient population. So the use of laparoscopic peroral myotomy was previously used as a treatment for gastroparesis, but the studies have shown that it did not have durability despite early response and increased emptying. So what we would like to know is what's different with the laparoscopic peroral myotomy procedure that the GPOM seems to offer other advantages. First of all, it's the least invasive way of getting that procedure completed. It's a true myotomy, and it may eventually have less scarring, but it would be great to study that in a formal fashion to know if the GPOM patients can have longevity in the symptom response that we're seeing. So when we have a gastric neurostimulator patient who either had a good response and now that response has failed, that we're not regaining a response with increasing the energy settings, then we want to think about adding additional therapy in. We also want to consider it when we're managing very well nausea and vomiting symptoms, but bloating, fullness symptoms also seem to be very symptomatic. And so we know we're limited with the gastric neurostimulator and the nausea vomiting symptoms. If they're still very symptomatic with bloating and fullness, we try to add those therapies together to hopefully the patient can have more good days than bad days. We will obviously say a failure of therapy is not averaging more good days than bad days. So greater than 60% of your days are with symptoms. We will want to add additional treatments.